Good day everyone! Today we will be talking about the peptic ulcer disease. Peptic ulcer is defined as a disruption of the mucosal integrity of the stomach or duodenum leading to local defect or excavations due to active inflammations.
Peptic ulcer disease is present in 4% of the population, with the lifetime risk for developing an ulcer is approximately 12% in men and 10% in women. It is higher in third world countries due to H. pylori infections, and an estimated 15,000 deaths per year occur as a consequence of complicated PUD in the United States. For the pathophysiology, we have three different levels of barrier when it comes to gastroduodenal mucosal defense. The first layer would be the preepithelial, which is mostly consists of mucus, bicarbonate, surface active phospholipids. And the second layer would be the epithelial, which is responsible for the cellular resistance, restitutions, productions of growth factors and prostaglandins, as well as cell proliferations. And the last layer would be the subepithelial, which is mostly consists of blood vessels and leukocytes.
PUD encompasses both gastric and duodenal ulcers. They share common features in terms of pathogenesis, diagnosis, and treatment, but several factors will distinguish them from one another.
Duodenal ulcer is most often present in the first portion of the duodenum, which accounts for about more than 95%, with estimated 90% located within 3 cm of the pylorus. Malignant duodenal ulcers are extremely rare compared to patients with gastric ulcer. H. pylori and NSAID-induced injuries account for the majority of patients with duodenal ulcer, and average basal and nocturnal gastric acid secretions appears to be increased. On the other hand, gastric ulcers can be attributed to either H. pylori or NSAID-induced mucosal damage, and gastric acid output tends to be normal or decreased in patients with gastric ulcer. This is just to show you the difference between the gastric ulcer and duodenal ulcer. Gastric ulcer is less common, with a small increase in incidence, which occurs later in life, with a greater risk for malignancy and normal or decreased basal and nocturnal acid secretions. While on the other hand, duodenal ulcer is more common, with decreasing incidence, which occurs earlier in life, wherein malignancy are very rare, with increased basal and nocturnal acid secretion and decreased bicarbonate secretions. Now we proceed to H. pylori and other peptic disorders. We all know that Helicobacter pylori is an ubiquitous organism present in about 50% of the global population. It is a urease-producing S-shaped, flagellated, gram-negative microaerophilic rod. The route of infections of H. pylori is either oral to oral or fecal to oral, and it occurs more frequently in developing countries. H. pylori infection is virtually always associated with a chronic active gastritis. Only 10 to 15% of infected individuals develop frank peptic ulceration. End result of H. pylori infection would be gastritis, PUD, gastric mouth lymphoma, and gastric adenocarcinoma. H. pylori is present in only 30 to 60% of individuals with gastric ulcers and 50 to 70% of patients with duodenal ulcers. And the pain awakes the patient from sleep. On the other hand, patients with gastric ulcers, uh, the discomfort may actually be precipitated by food. Patients with peptic ulcer disease can also present with nausea and vomiting. variation in the intensity or distributions of the abdominal pain, as well as the onset of associated symptoms such as nausea and vomiting, may be indicative of an ulcer complications. This peptia that becomes constant, which is no longer relieved by food or antacids, or radiates to the back, may indicate a penetrating ulcer to the pancreas, wherein sudden onset of severe generalized abdominal pain may indicate perforations. Pain worsening with meals, nausea, and vomiting of undigested food suggests gastric outlet obstruction, and tarry stools or coffee ground emesis would indicate bleeding. For the physical examination, epigastric tenderness is the most frequent findings in patients with gastric ulcer or duodenal ulcers. Pain may be found to the right of the midline in 20% of the patients. A severely tender, board-like abdomen suggests a perforation. Tachycardia and orthostasis may suggest dehydration secondary to vomiting or active GI blood loss. For the complications, we have three different types of PUD complications. The first one, which is the most common, are the gastrointestinal bleeding. The second would be the perforation, and the third would be the gastric outlet obstructions. Gastrointestinal bleeding is the most common complication observed in PUD, which is account for 50% of the population. Bleeding and complications of ulcer disease occur more often in individuals greater than 60 years of age. Higher incidence in the elderly is likely due to the increased use of NSAIDs in this group. On the other hand, perforation is second most common ulcer-related complications for about 6 to 7% of the population. The incidence of perforation in the elderly appears to be increasing secondary to increased use of NSAIDs. Perforations of duodenal ulcers has become less common in light of the increased rates of H. pylori eradication with NSAID-induced gastric ulcers, leading to perforations occurring more commonly. And last, gastric outlet obstruction, which is the least common ulcer-related complications, account 1 to 2% of the populations. It may have relative obstruction secondary to ulcer-related inflammation and edema in the peripyloric region. New onset of early satiety, nausea, vomiting, increase of postprandial abdominal pain, and weight loss should make gastric outlet obstruction a possible diagnosis. For the diagnostic evaluation, first would be the varium studies with a sensitivity of 80 to 90%, which is not routinely used anymore, since there is a need for verifications by endoscopy. Second would be the endoscopy, which is the most sensitive and specific approach for examining the upper GI tract, which allows the direct visualizations of the mucosa. It facilitates photographic documentation of a mucosal defect and tissue biopsy to rule out any malignancy or H. pylori infections. And we have different types of H. pylori tests. First one would be the urea breath test, a non-invasive and doesn't require esophagogastroduodenoscopy. Second would be the direct culture from an EGD biopsy specimen, an EGD biopsy specimen rapid urease test, and stool antigen test. So this is just to show you a table of an invasive and non-invasive tests for detections of the Helicobacter pylori. For the management, before the discovery of H. pylori, the therapy of PUD was centered on the old dictum by Schwartz of no acid, no ulcer. The mainstay of treatment for patients with peptic ulcer disease is acid suppression, which promotes mucosal healing and relief of pain, H. pylori eradications, and avoid complications of PUD. This is just a table showing you the drug which is commonly used in the treatment of peptic ulcer disease. We have the acid suppressing drug, which consists of antacids, histamine receptor antagonists, and proton pump inhibitors. We also have the mucosal protective agents, which is composed of sucralfate, prostaglandin analog, and bismuth-containing compounds. For the acid-suppressing drugs, we have the antacids, which is not used as primary therapeutic agent. which is used only for symptomatic relief. The most commonly used agents are mixtures of aluminum hydroxide and magnesium hydroxide, and also calcium carbonate and sodium bicarbonate. We also have the histamine receptor blockers, which inhibit the basal and stimulated acid secretions to comparable levels when used at therapeutic doses. This class of drug is often used for treatment of active ulcer in combination with antibiotics directed at eradicating H. pylori. The side effects of this are the following: pancytopenia, neutropenia, anemia, and thrombocytopenia. Next would be the proton pump inhibitors, which irreversibly inhibit the hydrogen potassium ATPase. This is the most potent acid inhibitory agents available, and acid suppressions lasting up to 72 to 96 hours. The side effect of this drug would be vitamin B12 deficiency, pneumonia, and hip fractures. For the cytoprotective agents, we have the sucralfate, which becomes a vicious space within the stomach and duodenum, binding primarily to the sites of active ulcerations. We also have the bismuth, which is the mechanism of effect on ulcer healing is unclear. Adverse effect with short-term use of this would include the black stools, constipations, and darkening of the tongue, and which is one of the drug used in H. pylori treatment. And last would be the prostaglandin analog, wherein the effect is through enhancement of mucosal defense and repair. The most common toxicity of this would be diarrhea, which is account for 10 to 30% of incidents. The major toxicities include uterine bleeding and contractions, which is misoprostol is contraindicated in women who may be pregnant. Now we will proceed to the H. pylori treatment. Dramatic decrease in ulcer recurrence to less than 10 to 20% as compared to 59% in patients with gastric ulcer and 60% in duodenal ulcer patients when the organism is not eliminated. The agents used with the greatest frequency include amoxicillin, metronidazole, tetracycline, clarithromycin, and bismuth compounds. The side effects during treatment are also common. So this is the regimens recommended for the eradications of H. pylori. So for the treatment summary, once a gastric ulcer or duodenal ulcer is documented, and if there is any positive for H. pylori infection, we can give the patient a triple therapy for 14 days, followed by continued acid-suppressing drug, which is histamine receptor antagonists or proton pump inhibitors for a total of 4 to 6 weeks, and then hold the NSAID. However, if there is no H. pylori infection, we can just give an acid-suppressing drug, either histamine receptor antagonists or proton pump inhibitors for a total of 4 to 6 weeks and hold the NSAIDs. And last, the last resort for treatment of patients with PUD would be the surgery. It's either elective for treatment of medically refractory disease or as urgent or emergent for the treatment of an ulcer-related complication. Surgery is more often required for treatment of an ulcer-related complications.
And that concludes my presentations. I hope you enjoyed my slides. Thank you.